Thank you guys so much for letting me be here. I do have to say that as an autoimmune patient, having to go through all of those different drugs until you find something that actually works is incredibly frustrating, and probably a little bit traumatizing to us. But thank God Jack's works, so we're good now. So getting to that, IBD affects all aspects of your life. Patients have ongoing fatigue, bowel symptoms, especially patients with perianal disease can have constant drainage. And then the patients that have a stoma, that affects them really greatly. So a lot of the current literature lacks any evidence that we routinely discuss this stuff with our patients. So nobody's talking about it. We have very strict time constraints on our appointments. You might have only 15 minutes to get in there and see a patient. You have a lot of younger patients in this population, so they might come in with their family members, their mom, their dad, and you may not want to talk about some of this stuff in front of those family members. And then also the rapport. So just like Dr. Gassier said, you have to build that up with your patients before they really feel comfortable with you. And so we're going to break this down a little bit into several different categories. We're going to start with male and female, fertility, pregnancy, and then the sexuality arm. So talking about the difference between male and female sexual dysfunction, so surprisingly, the rate is actually higher in our female patients, but still very prevalent in our male patients. And these are some of the independent risk factors for that. So steroid use, biologics, depression is a really big one, and we'll get to that later. Diabetes in men, and then, body image. So we give them surgical scars, we give them stomas, we change how they look and how they feel about themselves. And then also with a lot of weight loss, the patients can lose a lot of confidence in themselves. So talking about our female patients, these IBD symptoms can actually worsen during menstruation, so that can aggravate the underlying problem. Endometriosis is more common in these patients too. So maybe one good thing is that for women with UC, that IVF actually successfully overcomes some of their infertility, and that the use of biologics and these thiopurines through pregnancy are well tolerated for both the mom and baby. Some of the stuff like the JAKs still need more data with that, but the depression really impairs the quality of sex life. Sexual dysfunction is rarely discussed whenever we talk to these patients. So in the male patients, again, the sexual dysfunction present in about 20%, erectile dysfunction in about 30%. And both of these problems are highest in patients in their 20s. So, when they should be, young and having fun and making babies is kind of when all of this stuff is happening. So again, I told you we talk about depression. Depression and psychological problems are probably the most important problem in the male patients that contributes to some of this. So it is not actually disease specific, it's really a consequence of their depression. Let's talk about fertility. We're going to talk about pre-op and then post-op. So in male patients, luckily, their fertility is generally unchanged. So with some of the medications that we don't use as much anymore, but sulfasalazine, methotrexate, they may have some oligospermia with that. It's reversible, so generally we would tell the patients to be off of it for about 3 months or so. It's before they would start trying to have any conception. And then looking at this was a study that looked at 10 studies first, no difference in any of the different therapies, and then 16 studies with over 25,000 patients that again showed that they're probably safe in regard to fertility and any of the reproductive outcomes. So in female patients, this was a really nice systematic review that had a lot of patients included, and showed that fertility rates in the UC patients were about equal to the general population. Surprisingly, though, they tend to have fewer children, but this is by choice. And a lot of them cited things like, fear of passing it on to their children, or, problems with pregnancy. And so that was actually done by the patient's choice, not by any infertility. Now, fertility in Crohn's patients does appear to be reduced, and the disease activity is another really important factor. So we need to remember to try to keep these patients in remission if they are going to try to have any childbearing. So only one of them reported any reproductive assistance with that, and said that the IVF, again, kind of reversed any of the infertility in the UC patients, kind of bringing them back to the general population. So this was another interesting study, because we were talking about some of the gut microbiome. Here they were trying to compare the time to pregnancy between patients that were treated with fecal transplant. And they actually showed that it did shorten the time to pregnancy, comparing the patients that were already in remission, and that the pregnancy rate was higher in the group that had gotten the transplant. It also tended to improve some of their menstrual disorders, so it may have other benefits there, but that might be something to kind of consider with some of your patients. So looking at the assistive reproductive technology, so any kind of IVF type treatment, equivalent to women in the general population were pregnancy rates, the safety of this, and then the live birth rates, especially in ulcerative colitis patients. Again, we said that the Crohn's patients have it a little bit rougher, and so there the live birth rates were lower, and then especially after surgery and after failed pouches. So surgery is one of the factors that has the strongest risk for infertility, and that's maybe damage to the nerves, altered anatomy, fibrosis. We know some of those other psychological factors. Again, I told you this is going to keep coming up over and over. And then higher rates of things like hydrosalpinx, fimbrial damage, tubal obstruction, which are the most likely contributing mechanisms for those patients that have pelvic surgery. So two nice studies, one that came out of Denmark and then out of the US, talking about women with Crohn's disease that have had surgery, significant increase in the time to pregnancy, and then that fertility treatment is more common in patients with IBD, particularly those with pouches. So this was an extremely large study done by the Swedes that was over 50 years, looking at patients who had reconstruction, so pouches, some that had ileostomy where the rectum was left in place, or ileostomy that had had a completion proctectomy. In the female arm, following colectomy, they had lower fertility compared to the general population, and it was least affected in the patients where the rectum was left in place. And same thing with the males, the largest impact were those that had the completion proctectomy. So again, it's the surgery in the pelvis that is really the highest risk. So the postoperative infertility rate is higher after pouches, regardless of the mode of surgery. You know, we always talk about lap versus open. It actually doesn't matter. It's just it's the pelvic dissection, really. But those patients that did have a lap surgery did have a lower time to conception. And so that might be important to some of your patients that are kind of running out of time. Now, the lower study was pretty interesting. So they looked at quality of life in patients and kind of grouped them by age, or saw this difference in age. And the ones that in their 20s and 30s wanted a pouch, they wanted to be reconstructed, but the patients that were older said, I really don't care, probably just want an ileostomy. And they actually had higher rates of childbirth, decreased time to conception, and then over 75% reduction in their IVF use. So that's pretty significant too. So in pregnancy, so some of the disease course will definitely kind of translate to any pregnancy complications, even during the time of conception. So again, you want to get them in remission. That's usually when we recommend that patients will try to conceive. And then there are a couple of drugs that are strongly contraindicated in pregnancy, so your patients would need to stop that. So some of the other things that we see, mechanical obstructions and pouch complications. Some of the mechanical obstructions can occur from all the stricturing, adhesions, but pouch twists are really common too for some of these patients. They can usually be managed conservatively, may need some endoscopic decompression, and think about TPN to support them, and maybe early delivery for some of the patients. You can also follow them with fecal calprotectin and ultrasounds to see what's going on, and then put them on antibiotics and the biologics to try to keep their disease in remission. So this was another study that looked at patients that had their pouches done as kids and how they transitioned. I'll tell you that the fertility was good, which is why I didn't include that, but they did have two complications in that study cohort, small bowel obstruction for one and a pouch volvulus for another. So those are the things that you need to look out for. All right, so now the fun part, the sexuality. So I guess I always get this let's talk about sex thing now. Don't know where I'm getting this reputation from, but I'll go with it. So this was a large study looking at patients with UC and Crohn's, and then some with fistulizing disease too. A lot of them had stomas, and surprisingly more than 50% of them kept their stoma for 1 to 5 years. So it's quite a long time. It's not just, oh, it's temporary and we'll reverse it in 3 months. And so a lot of the patients said that there was alterations in their preferences in sexual positions, activity, and then their body confidence after surgery. And then most of them said that they were never available to discuss this stuff with their healthcare provider. So again, I think we need to talk about it. This one was very eye-opening, and I included a lot of quotes here, so you guys can kind of read them as I keep talking. But they went through a lot of different respondents, mainly from the UK and a couple of other places, that really said, we're not talking about this stuff, but we really want to. We really need to. So these are some of the overarching themes that this discussions aren't happening. Some of them said, I can't imagine talking about this. Oh, my God. Or, I'm a person, not just my IBD. It's not just my colon. And then many said that we just need to talk about it. Or sometimes when we did talk about it, we were really bad at it. So maybe it's not our place to do it, but we can potentially find them someone to talk to that can help them out. So like I said, difficult topic for discussion. A lot of them said never even been mentioned to me, hard to discuss face-to-face. This 17-year-old kid said, my mom usually comes with me. I have a really close relationship with her. I don't mind talking about that, but I felt like the consultants didn't want to discuss that with me with my mom in the room. And they're a person not in IBD, so yeah, we don't just take out their colon and then make them better. Like they have other things going on, and they mention a lot of times this kind of lack of curiosity. And I liken this. I remember my lap mentor in residency always said, "Be nosy. Ask them questions. You want to know stuff about their life because that tells you how they're doing and how you've affected them and made them better." So we need to talk about sex. It's a normal part of life. Kind of like everybody pees and poops, everybody has sex too. So, but we have to consider some of the other things. So, this second patient here said that they need to imagine what it would be like for them if they were worried about pooping on themselves during intimate moments. So that's some of the stuff that we may not consider, but is really important to the patients. Sometimes we don't think too just about simple things. We rid the patient of an abscess, but we leave in a ceton, and how does that affect them? Sometimes they can have pain, or I have a lot of patients that do come to me and say, how am I supposed to have sex with this? And so these are questions that'll come up all the time. So then other times too, they said, I just wasn't taken seriously. I mentioned all the pain that I was having to multiple different providers, GPs, surgeons, everybody else, and nobody really took me seriously. Or one that said, I got to the point that this is my labia going black and falling off, and I'm still not getting any attention. So we need to pay attention when they bring up these problems. So there absolutely needs to be appropriate time, space, and ways about talking about sex. So it may help to have specific clinic appointments to do this. And like I said, if we're doing it badly, maybe we put them in touch with, OBGYN or IVF experts and whatever, so that they can actually have those really meaningful conversations. So it is a team approach. I think building some kind of multidisciplinary, even if you don't have the facility to do it all in one place, make those connections with those different people so that you can get the patients to the right place. Also, one of them mentioned something that I thought was really a good idea, is maybe have a little small questionnaire that has this stuff, and they can kind of check off what their symptoms are, whatever's bothering them, and then you can bring it up later in the visit. So that might help there too. So also we have to discuss sexual minorities. So some of those patients, mentioned that, they have all this stuff going on, but add to that, she says being queer and it's pretty much hopeless. They're trying so hard to be careful with me as a trans man, but my bowel is kind of in a different body from my sexual organs. So we kind of need to take those patients really seriously. Yes, it's a very sensitive area to discuss, but we need to reach out to them and make sure that they feel comfortable talking about that with us. So in conclusion, you need to talk to your patients about this. This is part of the treatment of the patient as a whole, okay? We can't forget that. Treat their depression. It's the biggest risk factor for male and female dysfunction. And then the male fertility is largely unchanged. Female in UC patients can be overcome with IVF, but it is still decreased in Crohn's disease patients. And it's most at risk with any pelvic dissection or surgery. So don't hesitate to refer these patients to REI, not even like the typical 1 year of trying. It should be more like 6 months of trying before you send those patients off. And it's medically safe to treat the patient. Get them in remission. Get them on the biologics. Do all the things that you need to do in order to do that. And then be curious about their life. Try to create that multidisciplinary team so you can make it easy for the patient. And then that way they can get the treatment that they need. Thank you.